Great. Good afternoon, everyone. I trust you can all hear me clearly. Welcome to today's webinar on being a healthcare worker in a time of pandemic. I'm Dr. Nisha Jacob, Public Health Medicine Specialist and currently convener of the Navigating COVID-19 short course with Professor Francois Cilliers. As you all know, our final year medical students are preparing to return to the clinical platform, and we thought it would be useful for you as students to get a sense of what it is like to be a healthcare worker in this COVID-19 pandemic that we're all living through. So we have three fantastic speakers today who are all healthcare workers facing the pandemic in different ways and sharing different perspectives. And we are really grateful to them for coming on board at such short notice. So let's start off with the format of today's session. So first, we will have presentations from our three speakers, Dr. Shrikant Peters, Dr. Itumeleng Tatamala, and Dr. James van Dieren. I will introduce each of our speakers before they present, and they will speak for approximately 10 minutes each. During the webinar, you are welcome to send your questions via the Q&A function. And after each presentation, if time allows, we will have one or two questions of clarity. And at the end of the presentations, we will have a broader discussion, which will include your questions and reflections from our panelists. So today our panelists include sixth year students Ben Philpott and Lisa Kutsia, who have been actively involved in case and contact tracing, Dr. Karen Begg, Public Health Medicine Specialist and Deputy Dean for Undergrad at the Faculty of Health Sciences, Dr. Tracy Naledi, Public Health Medicine Specialist and Deputy Dean for Health Services at the Faculty of Health Sciences, and Professor Steve Reed, Head of Department of the Primary Healthcare Directorate. So without further ado, let me introduce you to our first speaker, Dr. Shrikant Peters, Public Health Medicine Specialist and Medical Manager at Groote Schuur Hospital.
Hello, everyone. So as Dr. Jacob said, my name's Dr. Peters. I am the medical manager of main theatre, anesthetics and ICU at Groote Schuur Hospital. I'm a public health specialist by training at UCT, and my undergrad was done at UCT as well. So I'm going to take you on a crash course of where we've been on a journey as the hospital. For the students that have left, I think, was it February or so, you would be coming to a very different hospital now at the end of May, start of June. Okay, so just where we are in the country in terms of the outbreak, we are at a sum total of 19,000 odd cases with 369 fatalities. We are at different levels of alerts as of June. Western Cape will definitely stay at alert level 4 and many of the major metros in the country. The Western Cape itself is bearing the brunt of the early stages of the epidemic, with 11,810 cases. In the last 24 hours, we've had 738 cases, and we're carrying about 2/3 of the death as well, with 235 deaths so far. Within our heat map, you can see Cape Town picking up very clearly, with Tygerberg District being the worst affected and Tygerberg Hospital being the worst affected, although we're not that far behind. In terms of caseload by province, we're at 1.78 cases per 1,000, and as that number diverges, I tend to not believe the other provinces, but what I'm told is they're 3 weeks behind us, so it's coming to them as well. At Groote Schuur Hospital itself, what I've got there are the numbers of patients at our facility, and the numbers in brackets are what we had 1 week ago. So 1 week ago, we had 46 PUIs, persons under investigation, admitted to medical wards. We had 45 cases, and now we've got 56 PUIs, and we've got 85 cases in our non-ICU beds. In terms of ICU, we had 13 patients in those beds, and today we have 21, at a maximum currently of 25 ICU beds, which we're attempting to rapidly escalate with equipment as we can find it. Okay, as you know, Groote Schuur Hospital is known for excellence, and we pride ourselves on utility and efficiency in the different components of the health system that we have to work with. We drive our people hard, we do our best work, and we try to use our finances as stingily as possible to the best possible outcome. And that's to have quality outcomes at the end of the day, better health, economic benefit to the country, and obviously confidence in our patients who use our services. We have our own framework of measuring indicators, which are completely out of sync to the normal year. We're escalating our equipment and supply chain and finance to be able to equip us with the resources we need to counter the epidemic. And we're working on national and provincial and local government plans to do this. So the national plan really hinges on de-escalating normal services, dividing our hospitals into COVID and non-COVID spaces, and then sequentially escalating the COVID service that we can offer. Now, based on modeling, the total the country has for ICU beds is 3,300, and at peak we're expected to need 30,000. So we're trying our best to scale up our hospital beds and decant in as synchronized a way as possible, but obviously it's a chaotic process, making beds, making wards, making healthcare teams where previously there were none. And even though a very small percentage of patients will ultimately require ventilation, because of the large proportion of patients becoming infected, that will overrun our system, both in terms of medical beds and ICU beds. The different stages that the country has laid out look nice on paper. Obviously, hotspots identification, lockdown, surveillance, and medical care and palliative care all go on at the same time. And because critical care is such a huge service, we're doing most of it ourselves. We're also doing some contact tracing in communities for our staff members. The province, as it's gotten the National Department of Health capacity plan, has divided their strategy into PHC, acute hospitalization, and they're looking at private resources as well. That relationship hasn't necessarily been set in stone, so we're not using private resources yet, but we're coming to call on NHLS's counterparts in the private sector to help us with our healthcare workers and our persons under investigation admitted in the hospital. And we may soon be calling upon them for ICU and inpatient beds as well, although that hasn't happened yet. The Western Cape has a 3-level command structure which has been established. According to military structure, we call it gold, silver, and bronze command levels. Gold is the provincial strategic command headed by the provincial premier and the Minister of Health. Silver falls within the provincial Department of Health and all the line functions that fall there. And bronze level command is the facility level operational control, which meets on a daily basis. And that's led by our CEO, Dr. Patel. So all hospitals have been told to create COVID and non-COVID spaces to manage infection control. We're trying to minimize infections as far as possible, although now we've almost worn out the C floor. We're moving patients to the D floor, G floor, and F floor in COVID designated spaces. As one of the referral tertiary centers, we are one of the few places that has critical care capacity to escalate, obviously within rationing of care. And so clinicians have been developing triage guidelines to escalate and then triage patients according to our resources, which are still finite in what seems to be an unlimited demand for services. The province is also scaling up acute hospitalization beds. CTICC, which is an 850-bed facility, is being planned to open on the 8th of June, and there are other facilities around the province. Obviously, they still need staff, and so those need to come from provincial resources as well as some community service personnel. In terms of critical care, we in total can scale up to 300 beds in the province, and we're asking the private sector to add 300 beds to a total of 600 in the Western Cape. So in terms of Groote Schuur itself, we have a testing center which is running on P4 deck, which is screening and testing staff. We have an escalation plan which has been developed through the national and provincial plans. Phase 1, which is now passed, is preparing for the deluge of cases coming through. Phase 2 was partial de-escalation, which we've also passed now, where we partially de-escalate OPD, theatre, and other services which would need ICU. We're now in full de-escalation as of Monday, and we are rapidly COVID escalating our services throughout the hospital. Okay, so as I've said, we've got the screening and testing center operating on P4 deck. We've got a permanent structure which is going to be built there. It's currently being built, completed in June. We have a lot of wards dedicated to COVID services. If you think of the hospital as an organism, you'd have to think of the COVID service as a malignancy, because it's growing along the seafloor. It's consumed C5, C6 theatre is a COVID space. It used to be trauma theatre, C9, C12, C13. Some of the psychiatric beds have psychiatric patients who are COVID positive, and the med-reg room itself. Some of the wards in the surgical floor, F floor, have been taken, and a lot of G floor, which is medical ward, is moving to COVID space. The old clinical skills ward, which we all have either very good or very bad memories of, is now a COVID space as well. Maternity has an MH theatre and MH rooms for COVID patients, and ICU has space on C, D, and E floor now dedicated to COVID. Staff are being redeployed as we speak to work in COVID wards and ICUs as they open. They are going to be led by team leads from medicine, either registrars or senior registrars, some consultants, and the team that falls under that team lead will come from other specialties, surgery, anesthetics, gynecology, you name it. The problem is with each positive healthcare worker case that we identify, there's a ring of high-risk exposures which may need to isolate at home, and we found that this can deactivate an entire service. Things escalate rapidly, so by the end of next week, we're expecting to need another 2 medical wards and 6-bed ICU by the end of next week. With all this, we have an ethical principle as we manage the hospital to manage uncertainty, to safeguard and protect our staff, and to provide levels of care and standards of care to both patients with coronavirus and those without. It's not an easy balancing task. To do that, we have to maintain a hierarchy of control in terms of minimizing infections of healthcare workers, and the same will go for students. We maintain all of the precautions required by National Department of Health in terms of physical distancing, hand hygiene, and mask wearing, as well as disinfecting of surfaces. National Department of Health has given guidelines on PPE use, and anyone in COVID spaces needs to adhere to those, including students themselves. So, in conclusion, the way forward, we're holding tight. We're expecting the pandemic to peak in the Western Cape in June or July, and the numbers required of Groote Schuur Hospital. We are going to increasingly escalate the number of services dedicated to coronavirus patients. We need rapid training and redeployment of our staff to work in COVID spaces safely and appropriately. We're going to get to our maximum capacity, and then we're going to have to triage patients effectively and fast. We need to ensure personal and physical safety of our staff members because from an ethical standpoint, as well as the fact that they are an entry for the virus into communities themselves, and they will deactivate large sections of the hospital if they contract the virus and have to isolate. We need to focus on mental health and well-being of all of our staff members, as well as management, as you can imagine. And to do this, we need communication to flexible, adaptive teams. So that's it for me for this presentation. Thank you very much. And we have a range of people I just need to acknowledge. Thank you, everyone.
Thank you very much, Sri. That was really a fantastic overview and really quite a complex task that you as medical managers have to do in this pandemic. Sri, just before we move on to the next speakers, I just wanted to ask you how you as managers manage the anxieties and fears of the staff.
So there are various questions that people want answers to that we can't necessarily provide them with. People want to know, are they going to be working in COVID spaces? They want to know what's the risk of working in those spaces. They also want to know what's the maximum capacity for COVID services. And even though we can't necessarily provide answers, we do where we can, and we have close contact with registrars, consultants on the floor. we can agree on principles. And I think there are certain ethical principles for patient care that we need to adhere to. Patients are still going to come in with neurosurgical complications. Trauma is going to come in. Obstetrics isn't stopping. And we still need to provide a basic level of service and support healthcare practitioners that are providing that service. And so we agree on those principles, and I think we move from there. I think the most important thing is constant communication with people who are on the floor, and managers have to be visible in the spaces where people are at risk themselves, and that's how we do things.
Great. Thanks very much, Sri. If there are any further questions for Dr. Peters, please do pop them in the Q&A. Dr. Peters may have to leave this webinar a bit earlier. As you can imagine, it is extremely busy at CritisCare at the moment. If so, we will discuss with Dr. Peters for some further feedback. But thank you again, Sri. We really appreciate the input and the overview. That was wonderful. So I think I'll now hand over to our next speaker. So we're going to have to change the order a little bit because due to some technical difficulties. So our next speaker will be Dr. James van Dieren. So all our presenters today are UCT graduates, but James is probably the most recent UCT MBCHB graduate, current Masters of Public Health student, and active member of the Western Cape Outbreak Response Team. We look forward to hearing from you, James.
Thanks, Nisha, and thanks, Sri. I also learned a lot from your presentation. So I'm just James to everyone. I will know a lot of your faces if I could see them, and I'm sure that some of you know me. I am currently working with the Outbreak Response Team in the Provincial Department of Health as part of one of the pod leaders for a contact tracing approach. And basically what that means is that we are the people who have been responsible for identifying cases once we have their positive results and contacting them, and to identify, once we have the case, to identify their contacts for a number of reasons. So simply to go through what we do is we contact cases that we receive from the NHLS and from other laboratories and private laboratories. We assess their clinical status, we determine when they were infectious and their infectious period, we give them advice on isolating or quarantining, and we identify their transmission risk to their family members and other contacts in the community, and if they need any support to assist them in isolating at home. We also follow up with them, and then we also trace the contacts that they have come into contact with to see whether these contacts are in need of testing, care and support, or whether they themselves or the case are in need of other further hospital care or higher level care. The second part of what this is linked to is something called community screening and testing. It's a different but linked process. This is the strategy for the identification of cases in high-risk geographic areas that has been applied on a national level and in the province. It was meant to identify cases early on and intervene in high-risk populations based on the heat maps that we have identified in our contact tracing process. So this includes things like community drives at community sites, hospital testing, and household level screening. So what's the purpose of these two approaches? It's obviously to rapidly identify cases and contacts, particularly in the early stages of the epidemic. We were attempting to slow and reduce transmission of virus to allow for both whole system preparedness and to increase whole sector capacity in the meantime. And then something that's undervalued but very meaningful is to reduce the fear and guide cases through the experience of having COVID. So obviously a lot of stigma attached, a lot of misinformation, and that's very valuable to cases. And then also to allow for the rapid escalation in treatment to allow for better health outcomes if needed. And then we also serve a purpose of disseminating information to communities. So this is something that Dr. Peters showed earlier. It's just pulled from the Western Cape data dashboard, which shows the number of cases as we see in the Western Cape province, and you can see on the left-hand side sub-district level data. Then showing the actual trends in the number of cases and the daily and cumulative caseload in the province. And for contact tracing purposes, there have been three sort of phases that we've worked through. The first is what I'm roughly bracketing as the import and import associated cases. So these were the cases that we got in the beginning of the epidemic, where people had traveled, had a recent travel history to a known COVID transmission area, and they often knew their point of contact. And we were contacting these individuals, most often from a middle or higher income grouping, and advising them to isolate. Then we started seeing sporadic clusters. As we entered the lockdown period, a lot of these clusters, which are accelerated outbreaks of COVID, happened in workplaces. Things like grocery stores or factories. A lot of the essential services that were allowed to continue during the lockdown were obviously where we saw these outbreaks. And on these outbreaks, you would see large numbers of cases in a single workplace. And then we move into the third sort of phase, which is community spread. This is where it is no longer just in workplace clusters, but where we see household to household transmission and direct community transmission. People that we contact are often not able to point to the individual that they came into contact with as a known COVID positive case. And so often we lose track of the transmission chains that we were able to identify with the import and import associated cases. And it obviously changes the way that we contact trace. The challenges that we're facing at the moment, obviously you only find what you test for. So as you know, the Western Cape is the largest burden of cases, and there's some evidence to state that it is due to things such as either an earlier seeding of the epidemic into the communities, or more extensive targeted tracing in clusters. We have had some occasion to test asymptomatic clusters in workplaces, where workplaces are paid to test all of their workers in private. And sometimes we've seen a large number of asymptomatic cases, sometimes up to 50% of workplaces that have had COVID exposure were positive on these large screening tests, which kind of shows that there is a large asymptomatic transmission burden as well. The test backlog is something that's becoming increasingly difficult in recent days, sometimes approximately 7 to 10 days from the date on which a patient tests until we get it as contact tracers, and obviously has a serious impact on the efficacy of contact tracing and testing. Because the purpose of the isolation is to reduce exposure to contacts during the infectious period of case, and if that first 7 to 10 days since somebody was symptomatic enough to test, and they've been waiting around or not in isolation and have been engaging with others, they obviously have a lot of their transmission risk has already occurred. False negatives, obviously, there are a lot of reasons that a test could be negative. It could be the PCR tests, particularly, they detect viral particles, and so it could either be too early in the infectious process for there not to be enough viral particles to be amplified, or something as simple as testing procedure. And so a false negative or negative result in a contact does not necessarily mean that that person is able to go about their life, and they should still be isolating if they are a confirmed contact. And then the issue of repeat positive tests. We have had a lot of workplaces requesting that their workers are tested as negative before they're allowed back to work, and this is not something that simply not something we can do, both because of the testing backlog and because of the nature of PCR tests that can remain positive for multiple weeks after the initial infectious period is over, and they often detect things such as dead viral particles. And so going forward, there's going to be a lot of changes in the testing strategy as it becomes increasingly prioritized for healthcare workers, high-risk individuals, and hospitalized patients to allow for efficacy in rapid turnaround for these tests, and to allow for effective treatment of these high-risk individuals. We might see a phasing out of the mass community testing that's currently been happening. This is just a well-known photograph, obviously to lead into some of the challenges that we have in isolating patients. With the patient in the household, the first thing that's difficult is to get in contact with the person. There's a lot of fear and stigma when you're calling somebody with a diagnosis. We, in the beginning, were able to make sure that the patient had been informed by their healthcare practitioner, but very often we are the first people to contact the patient about their results. The idea that this virus is incurable as a term often causes a lot of fear in people. They feel that it is a death sentence, and it can cause panic if not handled correctly. It's one of the most important things to reassure an otherwise well patient is that most of the cases that we do see will be managed at home and will not require further hospital care. And that's one of the things that we should do, is to inform them on what to expect, how long to expect the symptoms to occur for, and how to access care. There's things like the Western Cape call line that I've referred patients to. I know that some of the sick leaders have also been volunteering on this line. I've spoken to some of you. And then also just to look at the risk profile of people in the house. The individuals we're most concerned about are those who fit a high risk profile of the elderly, chronic diseases, respiratory and renal diseases. HIV, there's enough data coming out now that people are starting to do studies on this, but we are mainly concerned in those who are not viral suppressed or have been suffering from other signs of progressive AIDS syndrome. And we're not so concerned with those that do have viral suppression and have been taking their ARVs regularly, but it's important to assess this as well on the call, and to make sure that the patient does have access to appropriate medication, particularly as services are de-escalated. Pregnancy and breastfeeding is another interesting case. This past week, South Africa had its first neonatal death in a preterm infant, but we do allow for mothers to continue to breastfeed if they are positive, and we allow breastfeeding infants and mothers if taken into isolation facilities to go together. Okay, so this is the main crux of the issue. You often have to break bad news to the patient. It can be the diagnosis in itself, but it can also be to do with mortality. We've had cases where we have phoned and we have discovered that the initial case is deceased, and we then find that the family members were contacts. Often they weren't aware at the time, particularly if the patient was tested in hospital, or if the results for the test come out after the patient has died. We've dealt with funerals during the lockdown period, and a lot of challenges there in how do you have a safe funeral, and how do you ensure the connection with your family and friends at a time like that. In communities, overcrowding, single room shacks, communal ablution facilities, all the challenges to isolating at home. The gold standard would, or the preference would be to allow people to isolate in their homes, as long as they are able to stay in a separate part of the home and a separate room with separate ablution facilities. But this is obviously not possible in a lot of cases. It also comes down to food security. We do refer patients for food supplies, but often the demand far outweighs what is the capacity for supply. And a lot of people are reliant on day-to-day income, and therefore their informal work continues despite their having a positive diagnosis. And then, of course, denial and resistance. This actually happens across all social strata. It's sometimes due to the socioeconomic issues that we've shown, but also it can be due to just not having the appropriate information, or not knowing that you're meant to isolate while waiting for your tests. Quarantine and isolation, two different things. Obviously, quarantining isn't for contacts and isolation is for cases that have tested positive, and there are a lot of challenges to allowing patients to isolate at home that we've identified. Workplaces often demand repeat testing and work letters, and even after we've given this, we've had cases being turned away from their workplaces because of stigma in their employers who are not understanding the occupational issues there. And obviously, how do you isolate at home if you have all of these challenges? And so therefore, what has been implemented is the quarantine and isolation facilities based on our assessment of patients' risk. Cases and contacts in some cases can be offered alternative accommodation. And this is done through the Provincial Disaster Management Team. There's a number of facilities such as the Lagoon Beach facility where patients are isolated. They receive sort of airline style 3 meals a day, and they are assessed and managed by a medical supervisor and a nurse supervisor, and they wait out their isolation or quarantine period there. Had some challenging cases. One of the first cases I referred to isolation took the whole family of about 7 living in one home into an isolation facility, and the very next day the grandmother in the home had a fall and required urgent assessment at New Somerset Hospital, and so we had to arrange for ambulance transfer, for informing the ambulance team, for informing the hospital that they would be receiving a known COVID case, etc., etc. And obviously people need to continue to have access to their medical care needs. This is when isolating at home or with isolation facilities. If they are using chronic medication, if they need any other primary healthcare services, a specific action has to be taken to ensure that they do get them. Otherwise, it impacts on our ability to quarantine. So basically, I didn't want to go into too much detail on the data side of it, but it's a changing epidemic, and the value that we get from contact tracing has shifted from the initial outbreak, where we were trying to contain the spread of the early cases, into a more case management approach. It's obviously not just a clinical challenge. We have to address the social determinants of health, and there's some political points there that I won't get into. But it's also just about the value of the conversation to the patient and to the health system. If we are able to reassure patients and support them in managing the 85% of cases who will be managed at home, it reduces the burden on the health system, because patients will not be seeking unnecessary care, and that's one of the most important parts, I view. So thank you for listening. If there are any questions, just post them in the Q&A.
Thank you very much, James, for a fantastic presentation that really gave us a comprehensive summary of the multitude of issues experienced in outbreak response. So that was really great. If I could just ask one question, James. In this time of heightened anxiety, something that I struggled with when I also did the case and contact tracing is managing the worried well versus the ill person who actually needs to go to hospital. And it's sometimes a fine line to make that decision. And it's something all healthcare workers will face, be it on the phone or in person in a facility. And I was just wondering about your thoughts on that.
Yeah, it certainly is a problem, and it can take a lot of the energy out of being a contact tracer if 30% of your cases are following up with you and every time they have a new symptom. So I think the first thing is to give them all the information about what they're going to expect, so that they don't, every new symptom is not a surprise to them. If they do have a prolonged cough, even after the 2 weeks a period, or if they have some new symptom, loss of smell, all of these new symptoms that have been identified, not to view them as unexpected. And then the second thing is to make a clinical decision. A lot of the contact tracers, obviously, myself included, have limited clinical experience, but it's around the purpose of the case management is to ensure that those who do need care do get more rapid care. And so if there is somebody who's struggling with shortness of breath that is progressive, it is worthwhile referring them directly for ambulance care. But I think information sharing is the most important thing.
Great. Thank you very much, James. That was fantastic. I'll now like to hand over to our final presenter for the webinar before we start our panel discussion, and that is Dr. Itumeleng Ntatamala, who is an occupational medicine registrar at UCT and works at the Health Impact Assessment Unit at the Western Cape Provincial Department of Health. So over to you, Itumeleng.
Thanks, Nisha.
So Itumeleng, if you can just put it on slideshow, please.
Slideshow, I have shared. Are you able to see the slides now?
No, we could see the slides before. You just need to put it on the slideshow view so we can see it fully.
Is that better?
No, we can't see your slides anymore. Just share your screen and then put it on slideshow.
There you go.
Okay, we can see your slides, so you just have to, yeah, there we go,
Should be done.
perfect.
All right, perfect. All right. Good afternoon, guys. So as Nisha has said, I'm one of the registrars in occupational medicine, and I'm currently rotating at the provincial office. And part of what we've been doing is ensuring that all our facilities are ready and prepared to not only manage our healthcare workers who are employed by the province, but also visitors, students, and volunteers as well. So these are just some of the figures that we currently looking through, and we at the moment have about 407 health workers who are positive or have tested positive for COVID-19. This, of course, is probably an underestimate, as we do have, as James has indicated, we do have quite a bit of a backlog and still have to look at what other results are still going to come through. But at the present moment, we've got about 407 health workers, and 60% of these are from the public sector. What we are picking up, however, is that it's not only in the health facilities, be it private or public. We're also beginning to see high numbers of staff staff who test positive for COVID-19 in your long-term facilities as well. So these would be carers, it would be cleaners and so forth who are found or who work in long-term care facilities. So just a bit of revision from my side. As you enter back into the health facilities and get back into the platform, remember the distinction between your hazards and risks. So as you enter into the health facilities, you'll find a number of hazards, and hazards are really anything within the environment that has the potential to cause harm or has got the inherent capacity to cause harm. So a biological hazard like coronavirus would be regarded as a hazard. However, what we would like you to be aware of as well is that related to the hazards is the risk factor. So here we talk about the likelihood or the probability of harm occurring after exposure to the hazards. So if you were exposed to SARS-CoV-2, for example, and you were wearing full PPE, you were following all the protocols, the likelihood of harm occurring or the risk associated with that will be much lower than if you enter into a COVID-19 ward and do not wear the appropriate PPE, right? So that's just a basic example. Again, just looking at the various hazards that you will be facing in the environment, there are a number of biological hazards, and we are focusing our attention today and of course in the next 2 weeks on the coronavirus or SARS-CoV-2. However, I just want to remind you that you will also still face the various other hazards that you left before going home. So there's still TB in the workplace. It's still a huge problem for us. We still have got HIV and hepatitis B, particularly if you encounter needle stick injuries or mucosal splashes. So please, as you enter into the facilities, remind yourself, where will I go if I've got a needle stick injury? And many of our facilities have got occupational health units or casualties that are dedicated to assist you. Okay, so please just familiarize yourself, depending on which rotation you're going to, as to where do you go to seek help. Of course, there are other hazards such as chemical hazards. We have been advocating, and rightly so, for vigorous hand washing for more than 20 seconds, regular use of alcohol hand rubs. However, we are beginning to see an upsurge of contact dermatitis and irritant dermatitis, which is as a result of using a variety of chemicals on our hands. So please take care of yourself holistically, and should you encounter these problems, seek help. You also, of course, as Nisha and James have spoken about, there's the big psychosocial hazard that you will be encountering in the workplace. You will be encountering many consultants, many colleagues, senior colleagues who are under pressure, who are stressed, and at times it may appear that they are either reflecting this to you, but however, it's the type of hazards, the type of psychological hazards that we're currently facing. We have, as a department, put in a number of measures which I'll speak to, but it is important that as you re-enter the platforms, to just be aware of the stress levels that your colleagues and your senior colleagues would be under. And in terms of the COVID-19 risk determination, you will touch on these in the weeks to come, but relevant to occupational health, one would have to consider what the risk level depends on, and of course it depends on the agent, it depends on the environment or the activities that are performed. And I'm particularly interested in this because many of you will be observing activities within the various platforms, and you may have also be requested to assist in these. So you need to be aware as to which activities are pardon me which activities are high risk or very high risk, and ask yourself, am I really prepared, or have I taken all the measures in place to protect myself from these? Of course, there are also individual host factors, which I will also just touch a bit on. Okay, so in terms of the various activities or the nature of activities that would be considered very high exposure risk, so any activity that involves aerosol generating, so aerosol generation, so intubation, cough induction procedures and bronchoscopies. If you're going to be involved in these activities, just remind yourself that I'm literally entering or performing activities which are very high exposure risk. And a key question that you must ask yourself is, am I adequately protected to undertake this activity? Am I adequately protected to actually observe this activity? You may also be asked to handle or collect specimens of known or suspected COVID-19 patients. These are activities which are considered very high exposure risk, and you need to be, again, ask yourself whether or not you've got the adequate protection, and if not, highlight this to seniors or those around you. Of course, there are some activities which are considered not very high exposure, but still high enough, and these would be activities which involve exposure to working with known or suspected sources of COVID-19. So if you're going to be stationed next to a COVID-19 ward, or you need to go get a folder to write your portfolio or so forth, entering into a COVID-19 ward, be aware that you're now entering into a high exposure area, and am I really prepared? Am I really well protected? Okay, and of course there are some medium and lower risk areas which will be highlighted in the facilities. There are individual host related factors that I must make you aware of, and you will, again, as the deanery and others will be speaking through to you, that you need to be aware that if you've got any of these individual host factors, there is increased vulnerability of COVID-19 infection, and we're also seeing much more severe disease in those who are greater than 60 years of age, pregnant, above 28 weeks, and so forth. Right, so just think and look at the list itself and ask yourself, do I have any of these vulnerabilities, and have I adequately relayed this to the faculty and to those that I'll be working and to those who you will be working with. Okay. So what has been the approach that we've adopted as the provincial government? So there has been a number of policies that have been promulgated from a head office or provincial office perspective. However, as you have seen from my colleague at Proteskier, each facility is then expected to operationalize these and make sure that these the specific procedures and policies which bring effect the guidelines that have been provided from provincial hospital. And you will see as you enter into your facilities, you will receive induction as to what has changed, what has been put in place to protect you. And part of these policies include the OHS COVID-19 policies. There's been circulars instructions that look at individual risk assessment of work of our staff and employees. So you will notice as you enter into many of our facilities that staff members that are regarded as very vulnerable, including consultants that you may have seen before, would have been either been relocated, redeployed, or have had additional measures that have been put in place to protect them. And of course, there are other specific circulars which deal with how do we manage our employees when they contract COVID-19, and how do you manage visitors and students as well, and where do we refer them to. The approach that has been adopted is based on the hierarchy of controls that some of you may remember from the training that we've done. And of course, it would be impossible for us to, at this point in time, eliminate COVID-19, eliminate the coronavirus from our facilities or substitute it. So we've really put in a lot of effort to ensure that our engineering controls are in place, our administrative controls, and that PPE is actually available. I think what is also quite important from the hierarchy of control is that PPE is really the least effective of the controls. So simply using your PPE and not following the guidelines, the administrative guidelines that have been put in place, or closing windows when we need ventilation in our facilities, really defeats the purpose. Okay. And I won't go into great detail into these, but some of the things that have been happening at the facilities, you will notice that there's specific isolation areas. So British Gate has indicated what measures have been in place, but whether you go to a CDC, primary healthcare facility, or district hospitals, you will find that as you enter the facilities, there are specific areas that are isolated, that have been designated as isolation rooms. There's specific areas that have negative pressure ventilation. So just be aware that these are engineering controls that have been put in place to protect the employees on the ground and to protect you as well. And of course, administrative measures that have been put in place include implementation of policies, procedures that need to be followed strictly by all health personnel on the ground, and these include daily symptom monitoring to ensure that if you've got symptoms, you do not come in onto the premises, or that you are directed accordingly to health professionals, occupational health professional, IPC professionals that would be able to assist you. And of course, finally, PPE is being made available, and of course you'll be receiving extensive training and assessments on whether or not you've been on PPE usage. So what I then did was just to ask some of the colleagues on the ground as to what would they like to relay to you as students coming back onto the platform. And I think what really comes out consistently is that you need to please listen to your body and respond to it. We've had many instances where surgeons and other colleagues will admit when the results come through that they did have symptoms. They thought that it would be unfair to leave the team. They thought that it would be unfair to not form part of form part of the ward round, or they thought that they needed to respond to their patients and neglect themselves. So it really is a plea from the ground that should you feel that you have developed any of the COVID-19 symptoms, seek help. Speak to your supervisors, speak to student wellness, and get assistance. We have in our facilities ensured that all our health workers are also aware that if you are unwell, these are the channels that would need to be followed. Of course, with all the training that one receives, you may end up thinking that, well, I've been in the health environment for 6 years, I've never gotten TB, I've never had any elastic injury. However, this isn't the time to be complacent. So understand that all forms or all categories of health workers are getting COVID-19, and that there are measures that have been put in place for a reason. These measures are put in place to ensure that you are protected, to ensure that your colleagues are protected, and try as best as possible to please follow these guidelines. All right. Of course, there are the universal precautions that have been advised: social distancing, not sharing of utensils. We are seeing clusters where we've had health workers sharing cool drink, for example, or sharing utensils, and then a cluster forms because of that. Social distancing, clinical partners or your clinical partners. At this point in time, unfortunately, you will have to social distance, and even in the canteens and other areas as well. Okay, and most importantly, please take care of your mental health and psychological health. Seek help. We do have Metropolitan Health within the provincial government. You've also got various services within UCT as well. So should you feel overwhelmed, should you feel burnt out, please do speak up and seek help. All right, so thank you so much to Prof. Mary Ann Davis for the use of her slides, and to all my supervisors. Thanks.
Thank you very much, Itumeleng, for an excellent presentation with quite a good refresher on basic occupational medicine principles that our students have learned in second year and fourth year. And I think something that really struck me in your talk, and it's been raised in the Q&A as well, it's very interesting that many of the exposures in healthcare take place in the tea rooms and the recreational areas, which is a really stark reminder to us to not let our guard down when we move out of the clinical area. But thank you, Itu. That was an excellent presentation. I'd like to now bring in our panel. So as I mentioned, our panel members include 6th year students Ben Philpott and Lisa Kutsia, Dr. Karen Begg, Dr. Tracy Naledi, Professor Steve Reed, and I didn't mention at the beginning, but we are very pleased that our Dean, Professor Lionel Green-Thompson, was able to join us, and we're very glad that he was able to join us despite his extremely hectic schedule. So our panelists have been responding to many of your questions in the Q&A, and I thank them for that. We will try and bring in these questions in the discussion as well. So I'd like to kick off by first asking Ben Philpott, who's been involved in the case and contact tracing, to give a few reflections, as well as any questions for our presenters. And perhaps based on what we've just heard, if you could specifically reflect, Ben, on the healthcare workers whom you spoke to when you did case and contact tracing.
Sure. Thank you, and thank you for all the speakers for their wonderful talks. I think my main reflection on doing this contact tracing and case calling was that I was often phoning the case with a biomedical diagnosis, a biological diagnosis that they were SARS-CoV-2 PCR positive. Yet much of the discussion around that afterwards was about social issues, and things that came to light were things like overcrowding and poor access to adequate hygiene and water. So that was my main reflection point. I was just struck by that. And then with regards to healthcare workers that I spoke to, so I think initially in the pandemic, mostly I was speaking to healthcare workers as contacts. So these were GPs who cases had seen in the few days leading up to the diagnosis. And the GPs had simply dismissed their symptoms, their flu-like symptoms, as just the common cold or flu, and hadn't been wearing adequate PPE at the time and hadn't separated their waiting rooms for symptomatic patients and healthy patients. So, and I think as the pandemic progressed, then I started speaking to healthcare workers who were actually cases. So these included some nurses at public clinics, and yeah, I think initially there was quite a lot of fear in the GPs, and that they didn't know that they were exposed. But as the pandemic progressed, I think the healthcare workers really understood the issue and the magnitude, and they were able to deal with it a bit better. I think one of the questions I have based on this, so I've really seen the value in contact tracing, especially as a student. And my question maybe to the speakers was, what lessons have we learned through the public health response to this particular pandemic? What lessons have we learned, maybe things that we've done right and things we've done wrong, that we can apply to future pandemics? That was my main question.
Thanks very much, Ben. Itumeleng, any thoughts from your side on lessons learned from an occupational medicine point of view? And Itu, just before you speak, perhaps you can stop sharing your screen at this stage so we can see the speakers a bit clearer. Perfect. You just need to unmute it, Itumeleng.
So I think from an occupational medicine point of view, what we have been experiencing on the ground is that it appears that in many instances, it's either the reporting lines are not clear, or the reporting lines are not followed to the letter. So we have in many instances, when speaking to or when relaying results to health workers, it comes across clearly that even though they had symptoms, even though they knew that these were the procedures that need to be followed, they were not always followed. And I guess in many instances, you do have service pressures. You do recognize or realize that as the only nurse or as the only doctor on the ground, if I was to take care of myself, if I was to focus on myself, what would happen to the patients? And I think that's the message that we're now beginning to really reiterate, that it is best for you to come forth, get help, and protect not only yourself, but protect your colleagues, your co-workers, and of course, ultimately protect your patients as well.
Thanks, Itu. Shri, any comments from your side?
Sure. It's been mentioned briefly in the chat, but something we learned early on, our approach initially was to build our defenses on the front line and make sure, that in our COVID service delivery areas, we were fully trained and staffed and resourced with PPE. But what we've noticed is most of our healthcare worker infections have happened in non-COVID spaces, where we were simply caught off guard in the tea rooms between staff members. It hasn't been, by and large, patient to staff member transmissions. And that's quite reassuring, actually, because it means it's incumbent on management and for the university as a whole to train staff to appropriately manage COVID patients, either in simulations or in person, and it would be negligent of us to not train staff. It's sort of a different argument that's coming through that I think that is valid.
Great. Thanks, Shri. James, any thoughts from your side?
Thanks, Ben, for the question. Yeah, I think the two things that would have improved contact tracing, and we've definitely learned from, is that the value of that initial testing period, the actual advice that you get when you get tested as a community member, that you should be isolating at home, that the test may take some time to get to you, the actual contact details that you're getting, that initial test contact helps to allay a lot of the fears that patients do have after they've been tested. And then the second one is one that I kind of mentioned, which is that your role as a contact tracer, or as anyone who engages with a COVID-19 patient or with any other patients, that's not simply clinical. We've done everything from helping patients who fear community violence, to patients who need food parcels, to patients that need to access their chronic care medication. I know the term holistic gets thrown around a lot, but it really, you have to do all these things so that you can protect the whole service for those people who really do need intensive care.
Great, thank you, James. I'd like to bring in Lisa Kutsia, another student who's been actively involved in case and contact tracing. Lisa, some reflections from you?
Hi, thanks for the talks, everyone. They were really insightful. I think for me, like, a lot of the time was dealing with stigma, especially in healthcare workers. So I had an example of a community nurse who was caring for an elderly individual within the community who then tested positive, and the focus of the community turned to the nurse and her family, and there was a lot of anger towards her, and actually we had a bit of an outbreak of community violence while I was on the phone to her, which was obviously very distressing. And luckily we were able to send out a task team that worked in that specific district to go and diffuse the situation, and also just to educate the people in the community, screen all that community, and those who needed further testing were then tested. So I think that there was just a lot of fear within communities, and often it was put onto those people who were trying to help. Yeah.
Great. Thank you, Lisa. And that's quite an experience, you know, and it's amazing that you actually experienced that, even working remotely, that one was able to actually have such a profound experience as to what stigma actually does. I think this is a good place for me to bring in Dr. Karen Begg, who's also been actively involved in the case and contact tracing and quite aware of a lot of these issues. Karen, your thoughts and reflections on the talks, the questions that have been raised today?
Thanks very much, and I think that well done, particularly to the students who've raised some really insightful questions. So I think that what we've really realized in a pandemic of this size is that it really exposes the deep fault lines in our society, number one, and I think that that was shared by a number of our colleagues around the socioeconomic challenges, the poverty, the food insecurity, the violence, and those aspects. So it's really put public health, and certainly our broader healthcare system, as well as our broader system relating to social determinants of health, actually in the spotlight. So it's certainly up to us now. The lessons that we can learn are that we have to design a new normal going forward, that we can't revert back to what we've had. So that's from a rather big philosophical point. But I think that the other thing that we've really learned, and that most people find exceptionally difficult, is the uncertainty and the unknowns and the shifting sands all the time. So whilst we can all present with great assurance as we have today, and I'm very grateful for the presentations from Shri and Itumeleng and James, but I'm sure that they'd all agree that what they presented today has changed from what it was last week, has changed from what it was 2 weeks ago. So, you know, we literally are not only repairing the plane as we're flying it, but we're actually building the plane as we're flying it. And I think that that's particularly difficult. So lots of the questions that are coming up from students is also wanting certainty when in fact, in many cases, we can't give certainty. So we can plan based on what we know today, but actually things can change by next week. So I think that Dr. Peters presented around, literally the changes this week in terms of what's happened for wards. And so we were literally planning to use the G13 Skills Lab until about 3 days ago. And literally overnight, in fact, it wasn't even overnight, it was in a few hours. We literally were told that G13 was going to be needed to be used as a COVID-19 ward. And I think that's really difficult. It's difficult for all of us, but I think it's particularly difficult for students to understand that for some of us, we've been living with that uncertainty for a good 10 weeks now. But students have been in lockdown and not necessarily familiar with this shifting sand scenario. And we literally are having to think and be creative on a daily basis, and it's really exhausting. Just the mental load is really exhausting, never mind the fear and anxiety, just trying to think of things all the time. So so what we really, I think that the other lesson that we've learned is that we all work together. If we work together in a collective and collaborative way, that we all contribute to the solution finding. There are no I think that the biggest misnomer for the media right now is calling anybody an expert. I don't think any of us who are often quoted, and I think I'm on my 89th interview now in the past 10 weeks. And I still would not consider myself an expert at all. I think that all that we are really trying to understand and learn, and we might just be a few steps ahead of other people in that particular moment. But I think that we're all learning and all working together. And I think the case and contact tracing team, I'm sure that the students who participated will agree, was a steep learning curve, and we were all learning. Literally the scripts, I was the drafter of one of the early scripts, and I think we changed that script almost every couple of days just because circumstances were changing, and the kind of cases that we were dealing with were shifting and changing, and the kind of questions we were being asked to answer were shifting and changing. And so actually WhatsApp has become one of our most important tools, where we ask each other questions and come up with solutions all the time. So it really is a case of shifting sands and just being okay with that, that actually we're not going to have all the answers, and the answers are going to emerge, and that we can all find the answers together. Thanks.
Absolutely. Thank you very much, Karen. That is so true. And it is really one of the biggest challenges of working in this time, in whatever role we find ourselves in, is this uncertainty and this change. I think it's a good point, a good place to bring in Tracy Naledi, who's also been working in conjunction with both the university and the health services, to hear Tracy's reflections. Tracy, are you in?
Yeah. Hi, can you hear me?
Yes.
Yeah. Thank you very much to the colleagues for a very insightful and informative presentations and raising some critical issues. Let me put my video on.
Yes, please.
Raising some critical questions, and so I'm responsible for health services, and I think as students, when we go back onto the health platform, we need to bear in mind that first of all, this pandemic is happening in the context of a broader burden of disease. So you are all very familiar, and I think it highlighted that the hazards of HIV and TB are still there in the wards. So when we think about the burden of disease that is out there, that is still there. And the challenge is that because of the lockdown, because of the fear that we've been talking about, a lot of our patients actually have not been coming to the health services, number one. But also primary healthcare services have been de-escalated such that chronic patients, one of the students asked about the primary healthcare services. So what's happening is that patients that are chronic and stable are receiving or are meant to be receiving their treatment through a delivery system of some sort and community health workers, and those that are not stable are supposed to come in and be seen. But the services are still seeing acute cases. But as you've heard, I mean, it was interesting. I think it was Shrikant who was talking about the COVID-19 being almost like a cancer. Certainly, when we've been through to even the primary healthcare facilities in preparation for your entry into the system, that is exactly what we found, that the services are really de-escalating some of their other services and ramping up COVID-19 services. So this is something that we have to do, but we must also bear in mind that it does have future consequences around management of other components of the burden of disease. For example, some of the surgeons were talking about having to stop elective surgeries. And there are implications to that, in that those patients in 3 months' time will be a lot more acute with complications, etc. So, I mean, this is an incredibly difficult time for the health service as a whole. And as many of you are aware, the health system itself is quite fragile and has had many challenges. And part of the reason that in our country we've been talking about having a national health insurance or an universal health care, such that we can make sure that we have very strong health systems. Part of the reason that this is happening, for example, with patients not accessing services on the primary healthcare platform, is that our community-based healthcare system is relatively weak. You know, had we really invested, I mean, I was reading an article from some colleagues from MRC this weekend talking about the investment that, you know, many people have been calling for serious investment in community health services. Some of this would have been able to handle. So in as much as my colleagues have highlighted, I think around, this pandemic showing the fault lines on the social determinants and the poverty that has been out there and the impact on the most vulnerable in particular, it is equally showing the fault lines within our health system that have been there before. And I think many of us need to start thinking critically about really how we transform the health system such that we can provide universal health care. But we are here now, as they say in Lesotho, we are here right now, so we must deal with the present. And the present at the moment is that as health workers, as the health system, we are at the forefront of this pandemic. And I think we must not underestimate the fear and the anxiety that is out there that everybody has spoken about. So when you do go out there, first of all, you yourselves are, I'm sure, are feeling quite anxious and fearful about what it is that you're going to find. But I think, as Karen was saying, just bear in mind that the other health workers that you are going to be meeting have been doing this for how many, about 3 months now. And so they're tired and they also have their own anxieties. But I think in our anxiety, I think we must draw on each presentation, which was very helpful, that yes, we are afraid, yes, we are anxious, but as the health system and as a health sector, we know how to protect health workers. There have been decades and decades of research and interventions put in place around infection prevention control and how we can protect health workers. And some of it is dependent on ourselves as individuals and the responsibility that we take to follow the procedures that very nicely highlighted for us, as much as the health system making sure that they can provide protection and safety for health workers, but we have to also bear in mind that this is a global pandemic. So some of the issues are not necessarily as a result of glitches within the South African system. For example, availability of protective equipment, personal protective equipment, is a global issue. That we have supply issues everywhere. So certainly ourselves as the deanery, we have regular morning meetings with management at Grooterskloof, where we are looking at some of these issues and are working together, collaborating and partnering to make sure that we can support where we can in terms of strengthening the health system. But we are aware of what the impact is for teaching and learning, what the impact is for health and safety of staff and students. So as others have said, we have to be incredibly agile. So, this week, for example, we had meetings with management 3 times. We often have them twice a week. This week we had it 3 times. So we will have meetings as often as we have to, such that we can make sure that we can keep students safe and make sure that we can still provide services to our patients, because at the end of the day, we are last man standing. If we are not there on the cold face providing these services, there's nothing else for patients. So I think, but I think I'm very grateful for the team who have prepared you, such that I think with the materials that have been developed for you, and if you can draw on the lessons and that you've learned and the materials that you've been provided and do the things that you know you're supposed to do, I'm confident that all of us can come through this in one piece and survive. Thank you.
Thanks very much, Tracy. Tracy, I think one of the points that you raise is really the community and the role that the community plays, and the different issues in the community. You know, it's not limited to just the pandemic. And I think Professor Steve Reed has a lot of experience working in the communities and working at that primary level of care, and in fact, at all levels of care, adopting the primary healthcare philosophy. So I'd like to bring Prof. Steve Reed in for some reflections and some questions for further discussion. Steve.
Thanks, Nisha, and to all the presenters. I want to just be like an old man and say that I qualified in final year before HIV was named. We didn't have a single lecture on HIV. At least you're getting some exposure before you qualify. The point of that is that we need to be able to adapt and be flexible. And just one sort of framework thing that hasn't come through yet is that the reason that the minister sanctioned final year students to come back was not primarily in order to finish your qualification by the end of the year. The reason was primarily to assist with the health services. And I think you need to understand that, because in the minds of the health managers, you are there to help. And you'll come back to a platform, as Dr. Peters said, that looks very different to when you left it, where wards have been taken over, people are dressed up in the most extraordinary garb, and the social distancing is very serious, or the tea rooms are closed. So it's a very different situation. And I'd like to counter the somewhat fearful tone of the discussion so far with a note of the opportunity for learning in this process. My own sort of baptism by fire was through learning about malaria from scratch in KwaZulu-Natal. We didn't have any lectures on malaria, let alone HIV, and having to make a plan in the heat of the battle was the most incredible learning experience. So, you know, Ben asked, you know, what are we learning from this? I included that in some of my lecture. How do we adapt fast to the changing situation and really capitalize on the opportunities that are in front of us every single day? It's the most amazing opportunity for learning as a medical student. You've got incredible, it's incredible privilege actually to be in the front lines. And you probably won't like me to say this, but you'll look back on this experience in a couple of years' time and say, "Oh, I was there. You know, I was in the front line," and to reassure everybody that relatively the risk of COVID for yourselves is extremely low, of severe illness. We know that, so we're doing all we can to keep you safe, and you need to do that as well. But I think just to put I suppose a positive spin on the discussion, to say what an incredible opportunity.
Thanks, Steve. That was really insightful. and you don't look like an old man, but we value the insights that you give us from the past. Because I mean, I remember my lectures with you as well, where you would bring in stories from the struggles that this country went through, during the war, all kinds of those kind of stories, and now you have so much insight and experience to tell us about over the years, and I'm sure our students will also one day, maybe not appreciate it now, but also have a lot of insight and wisdom from this experience and what they've been through, and I think it's important to remember that in a time like this. And I'm noticing that even in the Q&A that a lot of the questions that the students are raising are relating to a lot of anxiety as to how this year will be completed from an academic point of view. It's natural for all of us as human beings to feel this uncertainty. But it's also important to look more broadly and use this as a real learning opportunity and an experience that will give us insight and a great deal of wisdom as to how we approach health problems going forward, and how we mustn't neglect other problems, and how we must come together in solidarity. So thanks for that, Steve. I think that's a good place to actually bring in our Dean, Professor Lionel Green-Thompson, for some reflections and discussion. So I'll hand over to you, Lionel.
Thank you very much, Dr. Jacobs. And again, thank you very much for an incredible discussion. So I've been trying to work out how to reflect on this afternoon. And I thought to start just with my own reflection of the difficulty of trying to keep the faculty going as a faculty when the world it was familiar with appears to be crumbling. Where how do you run HR in the context of a time where you really want to be treating patients? So that's a very real tension for the Office of the Deanery at the moment. I think those who are public health specialists in the team are probably more comfortable with the conversations that are happening around us than I am. But that's the real thing. How do you teach students in a time where the places in which they learn are so unfamiliar? But I am struck again, and I often regard it as quite cliched, that whole saying of umuntu ngumuntu ngabantu, and I want to use that to say thank you to the presenters who presented at the beginning, because in so many ways you're the faces of the students who are in the final year class across medicine and the rehab sciences. So it's been incredible for me to listen. One of the things that I'm realizing on these electronic things is that whenever I bend down to reflect, I just see how bald I am. But it's been really incredibly exciting for me to listen to such young people speak with such commitment to this space of uncertainty that we're describing. So my struggle with your request for reflection, Nisha, is whether I speak to students and try and interpret for them what the session means, or whether I just reflect on this space that we're in. And I'm gonna share a mix of things. I don't agree with Professor Reed that you've come back only for service. I think the deans made a case to the minister about bringing you back to finish your training. The part of it was to say, in the event that you needed, you may be called upon. The minister only spoke to the imperative to serve. But for me, the key issue is that what we may have lost over time in the training of health professional students is the fact that you only learn through service. You only learn because you place yourself at the service of the patients. And if the patients are only the diseases you learn, then we've missed a trick along the way. So for me, fundamentally, this period must be about how do we recreate a platform in which service and learning are indistinguishable. Because if we are able to separate them, one of the parts is losing because of that. But perhaps the thing that I feel most strongly about this period is as students return, I mean, one of the things that I'm having to deal with from this office is the incredible uncertainty and vulnerability of everybody across the system, from the most junior person to the most senior. And I'm hoping that as the students embark on this journey, we're able to show them as professionals, because you never see us afraid and uncertain. We're always talking with such authority, you know. It's so easy for an intern to make a third-year student look stupid, you know. It's the thing we do because we're doctors or because we're the head honcho in a rehab center or whatever it is. I think the rehab scientists do it better than we do, though. So for me, one of the biggest learnings that I think students will see as they come back, and I think I heard it, I mean, from Peter's talk about, Shrikant's talk about the fact that Grooteskies doesn't look the same to the way it did even last week. And even in this morning's conversation, more wards are being opened even as we speak. The notion of, as you're doing case contacting cases, you're encountering the very real impact of the social determinants of our people's health. It's a fundamental encounter. And then Itumeleng was talking quite naturally about the order of occupational medicine. But in what you were saying, I could feel the notion of our own responsibility in that space. It doesn't matter if you dress up in a moon garb and everybody looks like a moonwalker. If you take that off carelessly and you go outside and you fraternize in a way that is not in keeping with those prescripts, you're part of the problem. You know, even if you work in a fairly sterile kind of environment. And then somebody said, so there were two things that perhaps in closing my comment is really to ask the students, as you return, and I think my comment presupposes our currently very paternalistic approach to patients. We, the health professionals, know, and generally the patients accept whatever it is that we tell them. There's no questions asked. So I'm asking you as you return as final years into the platform, will you be coming as a patient or will you be coming back as a practitioner? Because taking one or other of those, and there are continuums all the way between those, taking the one implies complete dependence on somebody else to tell you what's happening. Coming as the other means that you have a role. There's a sense of agency in what your professionalism brings to this conversation. I think Dr. Begg spoke about the fact that we're fixing the plane while we're flying. So perhaps the other analogy is, will you come back onto the platform as a passenger to whom we will respond as an air steward will? When you press the button, we'll have to run and sort out what you need. Or will you come as the pilot? That in many ways, your whole team ensures that the flight is successful at the end. So I think I am afraid. I'm afraid that I feel like I want to go into the fray. You know, I can intubate. I'm an anaesthetist. I want to get back into the so-called cold face. But then I think, I don't know if my diabetes is as well controlled as it should be. You know, so I don't think I've been as afraid as I am in my whole clinical life. I think even running away from the cops in the 80s was not nearly as fear-filling as this time. So that's my thing, is really to leave you with that question. Are you coming back onto the platform? Because you have a choice. Are you coming back onto the platform as a patient who often doesn't have agency, or are you coming as a practitioner? But thanks very much, Nisha. This has been an exceptional engagement. I really have enjoyed it.
Thank you so much, Lionel, Professor Lionel Green Thompson.
Oh, please, Lionel, it's fine.
It's been really, really some very insightful comments and some profound words to think about. And I think that's a really good place for us to conclude today's webinar. You've given us some food for thought. So I'd just like to say a very special thank you to our presenters and panelists for an excellent discussion on very pertinent issues. And also thank you for what you're doing. All of you in your different positions, it's not easy being in those positions. And we really wish you all strength and fortitude in this difficult time. And we're very grateful that you could all give up some of your time to come and join us in this webinar today. I'd also just like to say a special thank you to Suleiman Da Costa and his team from ICTS for all their technical support today. And lastly, to the students for some very insightful questions. We will be posting the Q&A on Vula. And if you do have follow-up questions, we're happy to try and get a response from the experts. Obviously, we weren't able to cover everything today, and I apologize for that. I hope you still did find the session useful. I mean, I learned a lot of new things, and I found it very useful to speak to colleagues all experiencing the pandemic in different ways. We had hoped to have another speaker today who is an intern working at the front line currently, for you to get an understanding of what it feels like and the kind of role that you'll be taking on next year. Due to logistical challenges, she was unable to join today, but I will be posting an interview with her on the Navigating COVID-19 course site soon. So keep a lookout for that. And that's it from us. Thank you all and have a safe and blessed weekend. And we will see you for our second webinar next Tuesday at 2 p.m. Bye. Thanks.
Thank you, Nisha. Thank you, everybody. Bye.
Bye.